Hello and welcome to the webinar. My name is Julie Hashida and I'll be acting as moderator for today's webinar, Laying the Groundwork for Meeting QI/QA Requirements, Action Steps Taken, a production of the National Healthcare for the Homeless Council with support from the Health Resources and Services Administration Office of Special Population Health. This session is being recorded. This is a 1-hour presentation with the last 10 minutes reserved for questions and answers. Below the presentation slide, there is a chat box for participant questions and technical issues. Please type your questions or technical issues into the chat box at any time during the presentation. A selected number of questions will be answered at the end of the presentation during the Q&A session. The PowerPoint presentation and the recording of this webinar will be posted on our website at www.nhchc.org within 3 business days. I would now like to introduce today's presenters, Pat Christopher and Amy Petersen. Pat Christopher comes to us from the Charles Drew Health Center Homeless Program in Omaha, Nebraska. She is a graduate from the University of Nebraska with a master's in public administration, major in organizational behavior, and graduate from Bellevue University with a master's in counseling and a follow-up master's in clinical counseling. She also did a term as a returned Peace Corps volunteer in Kenya, East Africa in 1997. She is now the Homeless Clinic Coordinator and Behavioral Health Supervisor at the Charles Drew Health Center Homeless Program and has been with the Health Center for 8 years. So welcome, Pat.
Thank you.
Amy Petersen, in 2005, earned her master's degree in public health from the University of Michigan, Ann Arbor. Amy completed the Health Research Education and Training Program with the New York City Department of Health and Mental Hygiene's Continuous Quality Improvement Bureau, and interned with the New York City Mayor's Office of Health Policy to coordinate a citywide platform for addressing health literacy. She is a graduate of the Urban Studies Program in Chicago, Illinois, and completed the Institute for Healthcare Improvement Breakthrough Series training. She is also an alumnus of the Blue Shield of California Foundation Clinic Leadership Institute. From 2007 to 2011, Amy managed the Quality Improvement Program of the San Francisco Community Clinic Consortium, which is a partnership of 10 community clinics and health centers. The program serves more than 15,000 homeless in San Francisco annually. Amy recently joined the San Francisco Department of Public Health Community-Oriented Primary Care Team, where in an effort to meet the challenges and opportunities of significant healthcare reform, she coaches and supports 14 primary care clinics in data-driven quality improvement activities. So welcome, Amy, and thank you to both presenters for their time today. I would now like to pass the mic to Amy, who will get us started with the presentation. Amy?
Thank you, Julie. Welcome, everyone. This is part 2 of a session around laying groundwork for meeting QI and QA requirements. Today we're going to look at the case study from Nebraska, and I'm going to share some tools for doing QI work in times of change. These are the learning objectives that we hope you all experience today. And now I'm going to pass the mic to Pat, who will talk about the Charles Drew Health Center and their work with patient-centered medical home and quality improvement concepts. Pat?
Thank you. Hello, everybody. My name is Pat, and as you know, I'm the Homeless Clinic Coordinator for Charles Drew. I'm going to talk a little bit about our quality improvement patient-centered home. One of the things we currently are focusing on is the patient-centered home, which isn't new to us, but it is new because we have Joint Commission who's out here for the past 3 days, evaluating us. And one of the things that is really important to us is how we access and give comprehensive care, and we coordinate the whole process. The PDSA, which is the simple process that we use, is the elements of PDSA. We plan out the issue that we want to focus in on. Then we look at things that we need to do. How are we going to carry out the testing? How are we going to document the problem? How are we going to begin the analysis of the data? And once we do that, we go ahead and we complete the analysis and data, we compare the data to the predictions, and we summarize what we've learned. And then we go ahead and we initiate it. And what changes have we made, and what will be the next cycle? Each one of us have a part in the process. Again, it's the model that we consist of is the three questions that we look to is the aim, the measure, and how are we going to change. For quality improvement, all the managers in every department, we coordinate together. We meet on a monthly basis, and we review the quality performance measures identified within the specific department. The PDSA are initiated to track the issues that are being measured. Each measure has an attainable goal. We don't set our goals out so that we can't attain them. We believe that if we set our goals to be measurable goals, once we achieve that goal, we can move forward into a little bit more of a challenge. Each measure is reviewed and discussed at a monthly basis, so each one of us has to prepare a report that we provide on a monthly, each month for each of our, to be able to present to the team. Homeless performance improvement. Our homeless clinic has been currently addressing patient medications that have not been received by the patient. What we do, and let me explain a little bit down here about our medication process. Because we're on electronic EHR, our providers can generate through e-prescribing medications to our pharmacy or any pharmacy throughout Omaha and surrounding suburbs. For our homeless patients here, our main clinic has a small pharmacy which fills our medications. When our provider sends in the medication order, we know what shelter or rehab or detox facility that the patient is staying at. So the pharmacist will go ahead and fill the medication order, put it in what we call totes, a locked tote, and our delivery drivers take those totes to each one of the shelter, rehab, or detox facilities. We measure the. We used to carry our homeless medications down here and have our clients pick it up. Well, we were not in compliance with the regulations from the state by doing that, so we had to come up with a process. One of the things we noticed is that not only with this new process, we still have to measure to make sure that we're not sending out medications for other patients that don't belong in the shelters, in that specific shelter. So what I monitor each day, or what I track each month, is the types of issues that we have with performance goals. So 99% of the prescription medications that are generated through EHR to the main clinic pharmacy I track. So the measurement right now is that we want to go ahead and every time a provider generates an order, we want to make sure that it gets filled 99% of the time. That the prescription medications are being received at the shelter through transportation. So we're hoping that 99% of the time that occurs. The shelters are receiving delivery of the client's prescription medications, are held responsible for connecting the prescription medication to the client through the medication aid. Each one of the shelter, rehab, or detox has what's called in Nebraska a medication aid that pretty much monitors that medication being connected to the right patient. The medical provider at the homeless clinic have increased their knowledge of EHR's prescribing, so they're meeting the goal of prescribing those medications each and every time they see the patient, so they're getting filled in a consistent basis. Our outcome measures are, with each of the outcome measures that we have, we look at the behavioral health risks for our patients here at Homeless. We look at their drug and alcohol, their smoking, the smoking abuse, family planning. We do STD and HIV testing down here. The screening of the health disparities. We're in the Health Disparities Collaborative, which we measure asthma, cardiovascular, diabetes, and depression. We screen for colon cancer, breast cancer, cervical cancer, and prostate cancer. We screen for physical exams and screening for unintentional injuries, screening for behavioral health, and we screen for other programs and services. And the reason we do all this is these are our measures that were set, our goal measures that were set from HRSA, so that we have to meet these measures. The clinical outcome measures are reviewed every 3 months. The clinical outcome measures we provide a goal and a percentage of compliance. 1% of compliance is the U.S. national averages. The other set of compliance is the data collection, and we monitor our clinical outcome measures through our electronic medical records. It's important to note that the homeless population are transient, so some of our numbers are off, and they fluctuate due to the seasons of the year. An example of meeting our clinical outcome measures, the state of Nebraska has a colon rectal program in which the outcome measure and the goal is to address the colon rectal cancer screening between the ages of 50 and 74. The patients, these are for men and women between that age group. They fill out their own applications. What we do is we help them send in the applications for their colonoscopies. The compliance goal is set for these standards of 50%. Our standard is 50%. The U.S. average is 40%, and the goals that we reached are 61.4%. And that was based on a random selection of 70 EHR charts over a 12-month time frame for that specific age group. An example of a difficult clinical measure is behavioral risks of smoking cessation, the number of patients using cigarettes to curb drug and alcohol addiction. We have a lot of patients that come to us with dual diagnoses, and once they kind of get through the mental health portion or their alcohol and drug rehab portion, they seem to maintain that smoking issue that they pick up. So the number of patients are dependent on cigarette smoking to decrease their anxiety or of being homeless. The number of patients dependent on cigarette smoking to cope with their daily issues increased. So what we did was we monitored what was this outcome measuring show. What did this outcome measure show us here at Charles Drew? Well, the goal and percentage of compliance to non-smoking in the U.S., we set our goals to 90%. That's a high goal. The U.S. average is 85%. And we're at 80% right now as far as having people actively participating in reducing smoking, reducing their nicotine use. This is, again, a random selection of 70 EHR charts over a 12-month period. Our age groups that we measured were between the ages of 21 and 65. A while back, we did a technical assistance, and we evaluated a small clinic. And one of the things that we measured, or one of the things that we looked at, was the how-tos in creating a quality improvement process. What we found was we looked at assessing the clinic flow of the clinic. We assessed the current job requirements of each of the staff at the clinic. We assessed the type of services provided. We also assessed the time spent to provide the services. Then we determined and prioritized the current issues which they were having overall in the process of clinic flow. And then we looked at how to engage the staff in a QI process. And one of the areas of concern dealt with what we found that we dealt with, or they were dealing with, was their donated medications. Unlike in Nebraska where we cannot take donated medications into our homeless shelter, this shelter could take donated medications. So medications had to be logged and prepared and dispensed by the medical provider. The medication tracking was confusing and time-consuming. The utilization of one room to accommodate the storage and preparation was pretty overwhelming, and the lack of pharmacy tech or a pharmacist to explain the contraindications to the patient fell on the job of the medical provider. And there were liability issues that increased, the liability issues were increased due to the dispensing and the ability to ensure that all the contraindications were discussed. So there was a lot of work being done that if a pharmacist came on board even part-time, could eliminate a lot of the issues that the medical provider was having. So we recommended that the clinic possibly get a volunteer assistant with their partner up with their local pharmacy or hospital or medical center pharmacy to cease dispensing medications from the clinic, which, yes, that's, you know, in a way not good to do because you're treating your patient and you need to have medications on hand. Or to set up a partnership agreement with a local pharmacy instead of just having a volunteer come in, set up an agreement where they would help you dispense the donated medications directly to the patient. Or initiate a grant that would assist in designating funding to create a pharmacy or an in-house pharmacy to regulate the donated medications and dispense the medications directly to the patients. The staff duties that we found that were affecting patient flow were the duties everybody was doing everybody else's job, or instead of filling in when necessary, everybody was crossing everyone's job. So that, you know, you'd have an MA doing one thing and another MA doing another thing, so there was a lot of time being wasted. The staff was wearing many, many hats, and there were no outcomes that were shown for success. In other words, you were starting a process at one point, but we weren't seeing the end result. Because of a lot of the confusion and not having a good flow from the front desk all the way through to the MA, through to the medical provider, there was a decrease in billing that was causing them to not collect the maximum amount for payment. And the customer service skills were decreased due to the overstretched duties and the many hats that were worn by the staff. So when you get somebody in a situation where they're doing multiple tasks, and they're not used to it, they have a tendency not to be very stressed out, not to perform to par, so their customer service skills decreased. The medical provider was doing nursing functions, which she didn't need to do, and therefore was limiting the number of patients that she saw per day. What I recommended solutions to that was to clarify each staff member's job description, just making sure that everybody knew what they were supposed to do and understood that if they needed to fill in for a specific person, those opportunities came when that person was either sick or there were numerous patients that needed to be checked in or vitals needed to be taken. Needed to have clear boundaries in the scope of practice for each of the staff. Each staff needed to know what are their boundaries, and crossing those boundaries, what would happen, and creating a clinic flow sheet including the process of check-in through checkout for each of the staff to participate through the process. So they understood what happened from the moment the patient came in to the moment the patient left the clinic, so they could see an accurate flow of what everyone did, and identify duplication of work by the staff. Was one staff doing the same thing maybe the person, maybe the MA that was checking in the patient, was doing this, was having the patient fill out a demographic sheet, but the patient was going back into the room and demographics were being asked of the patient at that time. That's a duplication of paperwork. When you've already collected it, you don't need to collect it again. Developing a structured flow where the staff understood their complete jobs, the skills that they needed to perform, and the tasks assigned to their job description. The operation of clinic was key to the success in the development of quality measures and goals. So the clinic daily flow from the check-in to the check-out of the patient needed to be identified. The collection of data, which measures the key components which affect the patient care needs. In other words, what data were they collecting to make sure that they were in sync with the flow of the clinic? Were they meeting the goals that they needed to meet? Say they wanted a patient in and out of the clinic within 40 minutes. Were they maintaining that time span, or what identifiers did they identify that they weren't meeting that specific measure? Measuring areas of concern, identifying and measuring areas of concern one another. Were they able to identify those areas that in the system that were breaking down? And then identifying areas that would promote success. That's important and key if someone's doing well or the process is working well, to really identify those areas. And then create ideas that would move the clinic to self-regulation, where the staff enforced the quality measures and goal setting based upon the buy-in belief. We at Charles Drew really believe that if you get a staff member to buy into their jobs, to buy into what they're doing for the client, you don't have to ever tell them that they need to pick up the pace, or you never feel guilty about asking them to maybe take on another task, because they bought into the process. They believe in the process that you have in place, and they believe in the patient's well-being, and they know what their goals are to be achieved. Now I'm going to pass it on to Amy.
Great. Thank you, Pat. So I'm going to talk a little bit about some tools that might be useful to all of us as navigators in these times of great change within our health systems. And I know the term navigator might be overused at this point, but all of us are working through tremendous aspects of change management. So my hope is that 4 of these tools might be useful to you as quality improvement leaders, and then I'm going to talk about 2 concepts that I'm hoping may also be useful to you. So we know that there's lots of change going on. I'm not going to harp on each of these bullet points, but I just want to make some room for us to acknowledge what's happening in the environment. The first tool I'm going to talk about is the Fishbone Diagram. So recently, within the Department of Public Health, we used the Fishbone Diagram to look at the concept of colorectal cancer screening, which Pat also talked about, in our homeless patients. And with the San Francisco Department of Public Health, our goal is that 60% of our patients are current for colorectal cancer screening. The Fishbone Diagram is a great tool for teams. You can start by asking a question about why a certain problem exists. So in one example with colorectal cancer screening, where the question is, why aren't our patients up to date? And with a small team, you can list some of the causes that the team identifies for the problem. Then you can categorize the causes into different buckets. There's causes that are more about the process or the workflow around the outcome. There are causes that are around roles or skills of the people involved in the process. And then there are causes that are related to patient factors and environmental factors. So here's an example of a Fishbone Diagram that was used to discuss the issue of missed opportunities for getting immunizations up to date in our children coming from families who are marginally housed. So at the head of the fish, you see the problem, and then along the bones, if you can read there, you see some of the causes. So there's issues as we move towards EMR implementation with looking for decision support tools, and then there are also causes around roles and responsibility. In the bottom right corner, you'll see that one of the issues identified were just trust between providers and the medical assistants that they're working with, that the medical assistants knew the guidelines and could act on the guidelines regarding immunizations for different patients coming into the health center. The next tool is prioritization grids. These have been used a lot lately in our system, namely to choose or narrow the scope for the actual number of improvement initiatives that you might be working on within your different center. We have a lot of things coming at us. There's meaningful use, there's EHR, there's team-based care, there's patient-centered medical home, there's pay for performance. When you have a lot going on, prioritization grids can be quite useful in kind of narrowing the focus of your QI team or your QI committee to just focus on a couple things. Primarily, you want to hone in on what the measures or the outcomes that you're working on and divide those up into a list. And in this exercise, you sort of, I'll give the example of looking at different measures. So let's say that you're looking at 5 or 6 meaningful use measures and you want to focus on which measures that you can put your resources towards improving over the next year. So you're going to set up your prioritization grid. You can project a grid like this onto a wall and use it during a meeting, or you can print this out on pieces of paper and explain the concept to your team. Here is the grid. So on the x-axis or the horizontal line, the question is how easy it might be to do something. So if you're thinking about a measure that you want to improve, one of the issues that we often have to tackle is how readily can we report on this measure? How easy is it to get data so that we can track our performance as we test different PDSAs and change concepts? So that's the ease of implementation. Low is, it's not easy. We'd have to do chart reviews or manually extract data. High is that the system affords us a lot of ease in pulling out data for a specific measure. And then along the y-axis or the vertical axis is the impact. So one of the examples that came up recently within our HCH sites was we were collecting performance data on the percentage of our patients who had their tetanus or Tdap vaccinations up to date. And one of the providers said, tetanus is really easy to get. The data is easy for us to get out of our system, so the ease of implementation is high. But the impact from this provider's perspective was pretty low, and he had cited some data from the monthly MMR report showing that there had only been a couple cases of deaths from tetanus within the last year. So it gave us some pause to think about why we were spending so much time collecting and reporting that measure. So here's just an example of one of our HCH providers explaining how the prioritization grid worked. And he put up his measures on the grid, so you can see that some are on the far right, so easy to get and high impact, and some are on the left, so harder to get but a high impact. And then here's the grid full, so the team each takes a couple measures, thinks about the measures, discusses them with their partner, and then places them on the grid. And then there's a larger conversation that goes on within the QI committee about where the focus will be. The next tool are dashboards and data walls. So dashboards and data walls are primarily used to keep your team and your clinic engaged. Run charts are used to trend progress. There's 2 panels that hopefully you can see. On the left-hand side, there's one panel of a sort of a 7-panel data wall that we use in our health clinics, and it shows demographic data. So we have about 3 or 4 operational measures and then 6 clinical quality measures. You see some of the quality of care measures on the right-hand side. And the data wall is meant to engage sort of all aspects or all roles within the clinic. So our front office and receptionist staff are really interested in seeing how their panel size data changes over time or how their third next available data changes over time. And our MEA and provider staff are interested in some of the key clinical outcomes. Here's a few quotes from a survey that we conducted recently, asking people sort of what the data wall meant to them in their clinic. So you can see that there's some pretty positive responses. Of course, I chose the most positive to show you. So process and workflow mapping. This is a great tool for EMR preparation or any kind of major change in patient flow or work process. The who, why, how results here emphasize in the who section that when you're doing some process mapping exercises, you want to make sure that in your small team you have at least one person who's very familiar with the existing process. And oftentimes what I've observed is when you start the process mapping exercise, people really want to map the ideal process, so how they think things should work or how they really believe things work. But it's important to have that expert in there because you want to map the process as it exists. And oftentimes, just because we've been paper-based for so long and our budgets vacillate from having staff to not having staff, processes become very complicated, and we rely a lot on institutional memory for how things work as opposed to sort of standard policies and procedures and workflows. We found this exercise useful when trying to reduce the amount of faxing, so again, paper-based work in our system, and trying to move to electronic communication. So we found with things like abnormal lab results, the lab result would be faxed to the nursing station, and the nurse would print out the information and make a copy of it and put it in another nurse's box, and then the nurse would get that and write something on it and put it in the provider's box. And we found that those kinds of processes were becoming quite inefficient, especially when we had more access to putting some electronic processes in place. Pat alluded to this idea of trying to clarify roles in different processes. So we found that when you can use a process map or do some workflow mapping, you can also clarify for each step who does what. And sometimes you'll find that multiple people feel ownership over a certain process, and that might be an opportunity to do some role clarification. So here's an example of how process mapping really worked for one of our health centers. This was a Curry Health Center who serves primarily 55 and older marginally housed senior citizens. They did a process map back in January to try to break down some barriers for electronically documenting blood pressure. So getting ready for electronic health record implementation. They had computers in their clinic, but they were finding that the percentage of patients who had their vitals recorded at their visit was really low. You can see the run chart down at 20% in November of last year. After they did a process diagram, they found that medical assistants were trying to go from the vital station to the room, back out to the computer to enter the vitals, and then back to the patient to do some health coaching and all the other things that our valuable medical assistants and nurses do. And they found a simple fix. It was to put the computer in the room with the vital station next to the computer. So the last two things I'm going to talk about are more concepts as opposed to tools. So we're nearing the end of my piece. Atul Gawande had a popular piece in the New Yorker maybe over a year ago, and he talked about this concept of cowboys versus pit crews, and providers, NPs, and medical staff have traditionally sort of worked as cowboys, doing it all, taking care of their patient panel. And what we really want to move to is thinking about our patients as needing a team. So moving from the concept of cowboys to pit crews. So you see the cowboy on the left side, and on the right side, a pit crew that works at a NASCAR event. Everybody has their role. There's somebody who's responsible for putting air in the tires, another person who's responsible for I don't know, getting the driver a glass of water, another person who's responsible for checking the oil. I'm not too fluent on what goes on in a race car, but you can see the example here gives a sense of this contrast. We've tried to move towards team-based care and to the pit crew model by just starting with team huddles, so pairing our medical assistants or health workers, as we sometimes call them in our system, with a provider. So the team huddle is a dyad at this point, and the real objective of the huddle is to spend no more than 15 minutes sort of planning for the day and looking at the list of patients who are scheduled to come in and trying to reduce the care gaps of patients on that list. The huddle uses an agenda, and we're trying to beef up the skills of our medical assistants so that they can lead the huddle and really own the huddle. We've seen really significant improvement in outcomes. We've had a few different providers who are medical directors at our health centers show the difference in patient outcomes from pre-huddle and pre-MA provider dyad, and then post-MA provider dyad, and for things like colorectal cancer screening, mammogram up to date, diabetic testing up to date, you see a real improvement. So the message is kind of like, we weren't really doing that great before we had dyads and before we were moving towards team-based care. And this concept in action is really leading to better patient outcomes. And again, it kind of gets at that trust and confidence issue that we saw come up on the Fishbone diagram earlier. Here's a basic agenda from one of our health centers that's been working on team huddles. These are the things that they talk about. So scheduling issues, one thing that we really wanted to get clarified between our provider staff and medical assistants is how providers prefer to have interruptions take place. We have a lot of providers in our system, especially our, very committed and dedicated HCH providers who want to spend a long time with our patients. And of course, we all know that sometimes that extra time is useful. Other times it can really back up the flow for the rest of our patients and the other patients who are trying to get access to their provider. So having a conversation about how a provider chooses to be interrupted, is it the mid-visit knock, or you do two knocks at the door and peek your head in and let the provider know that their next patient is there, or some other sort of patient-centered but access-minded interruption technique. One of the clinics that we work with refers to this dyad or team-based care concept as doing the team dance. And this is one of the slides that they've used for their presentation to talk about team-based care, and I thought it was nice. I think we're all feeling a little bit overwhelmed, and personally, I think that's just the nature of healthcare now. These tools might be useful to you, but in general, I think we're going to feel overwhelmed for the next couple of years. So part of it is just getting comfortable with that sense of being overwhelmed. But as quality improvement leaders, I also think it's important to consider how we might show the way or provide some perspective on what our journey is going to be over the next few years with our teams and with the staff that we work with. One of the reports or monographs that we found pretty enlightening and basic enough in terms of concepts to use as a sort of a guiding mantra with our teams is the building blocks for primary care. The California Healthcare Foundation published this monograph a couple months ago, and it was written by a couple of researchers who are out here at UCSF. The bullets of data-driven improvement, empanelment, these are sort of the concepts or the building blocks that the monograph espouses based on case studies at high-performing primary care health centers across the country. And these concepts can be talked about. We've seen different medical directors or health center directors sort of use each concept at different staff meetings. So start with one and talk about what it means and then link it to some of the changes that might be going on in your own health center or health clinic, just to give people a sense that, we're not trying to just make change happen because it's fun. This is something that's going on nationally, and that a lot of leaders and people who are, thoughtful about what we need to do to transform primary care are considering, and this is why a lot of change is going on, and this is why it can sometimes feel overwhelming. I just want to allude to some of the teams that I work with really closely out here in San Francisco at our Healthcare for Homeless sites. These are the teams: Southeast Health Center in the Bayview, Chinatown Public Health Center, and Maxine Hall Health Center out in the Western Addition. I learn everything and more from the innovators and leaders at these health centers. And my last slide is just some links. So a driver diagram, some didactic material on teaching process mapping, some other information on how to do fishbone diagrams, a great video on the team huddle, and then, of course, a monograph for the building blocks of primary care reports. And now we're going to open it up for the question and answer session. So you can type your questions in, and I think Julie is going to read them off for the presenters. And I think we're good on time, so let the questions flow.
Great. Thank you, Amy. And thank you, Pat, for both of your presentations. I will now begin the Q&A session. The first question is for Pat. We received during her part of the presentation was just a clarification or just some more information around how their referral process works for the colorectal cancer screening at the Nebraska clinic, and who provides that testing, and are there any costs associated with it? So, Pat.
A referral process for the colorectal screening occurs when the provider sits with the patient and identifies that the patient needs to have this process done, this procedure done. An application is given to the patient fills out the application, or we help the patient fill out the application, patient sends it in. The state of Nebraska doesn't like them doing any of the, any testing prior to them filling out the application. They review the application, they'll contact us if they need any medical records sent to them. The decision is made based upon the questionnaire that the patient fills out with the application. If the patient is accepted into the program, which 99% of them are, they're scheduled with a gastroenterologist that sees them first prior to doing the colonoscopy. The patient will go ahead and have the colonoscopy done at no charge. This is free of charge to the patients who qualify in the state of Nebraska. All of the doctors that participate do this free of charge. So it's a grant-funded program that they've kept going through, what we call the Every Woman Matters program. They included the colorectal program into it, and I kind of commented on they should change it to Every Person process, because it's now including the male, not only the females. But it's one of the better programs that the state of Nebraska has for that age group and screening for colorectal cancer.
Great. Thanks, Pat. Pat, another question for you, too, about the technical assistance visit that you did a few months ago. It's asking, can you describe how you and the other consultant were assessing the patient or workflow? And so how were you able to find duplication of work by staff during the visit, if you were able to do that during the visit? And so basically, how were you able to identify these issues while you were on site for the TA site visit?
One of the unique things that we do as a team, the person and I did together as a team, was to really talk to, first of all, the medical personnel, the medical provider, as well as the staff members that were doing the protocol. One of the things I kind of wear is that counseling hat, which, you know, you kind of hone into asking the question, well, tell me a little bit about yourself. Tell me what you do. Describe your job to me. And when someone tells you, well, I do everything, and they really don't really have a job description, or they really don't have a specific job, and they have this global, well, I do everything. Well, tell me a little bit about what you're doing. The disjointedness in their description gives you an indication that they're doing multiple tasks, but never coming out with an end result. And it's almost like piecemealing. They take one, they do one thing at one point, then they go and run and do another thing at another point. I'm going to give you an example. When we talked to the medical provider, the medical provider was entering information in their EHR, but she was also entering information on the paper chart. So that was kind of doing doing the same thing. So she was doing and then she'd have to go back and do what we call rework if the information didn't coincide with the EHR versus what was in the chart. And it's a lot of, and we had this here with our medical providers, it's a lot of, well, the EHR is here, but will it retain all the information? In case the EHR goes down, I need to make sure that it's in the paper chart. Well, it's getting them to understand that once it's in the EHR, you know, you've got a real good EHR, if you bought into a real good system, the system's going to retain the information that you have. Even if the system goes down, you're not going to lose that patient information. It's reassurance. It's a lot of reassurance. And a lot of that, you know, you see a lot of counselors doing a lot of reassurance. So I come in with the, you can do it, I'm the rah-rah person, I identify it, and then we move forward. And it was easy. It's an easy process for me to be able to identify when someone has difficulty working through a process and is really doing multiple things. So between my partner and me, we were able to identify some of the things that were going on and some of the stressors and the multiple tasks that were happening. I hope that answered your question.
Great, thank you. I believe it does. So the next question that we have from our audience, it's going to be to Amy. Amy, what kind of information does a team have in front of them in the huddle? I believe that's the dyad groups. And just this, so do they have just the schedules, or are they looking at the charts, the EHR, or paper?
Yeah, it's not standard yet, and I think that's because it's still trying to be figured out. You know, the conflict is that you want the huddle to be quick, but you also want to sort of plan for the patients that are coming in. So the most standard thing about the huddle that I've observed is this sort of schedule check in the beginning. So, you know, I'm here today, or I'm leaving for a doctor's appointment, sort of the schedule between the provider and the MA, and then you're also looking at the schedule of patients. And sometimes it's a discussion, you know, if you have this panel for a while, you know your patients pretty well. So it might be, you know, Mr. Jones is always late, so if there's a drop-in, I'm going to try to fit them in, expecting that he'll be, you know, 15 to 20 minutes late. Or we know that Ms. Smith always brings her child with her, so let's just be prepared with that. Or we know so-and-so might take some time. At some of the health centers, you know, they've become quite advanced, where the medical assistants have been trained to scrub the record the day before for the patients that are scheduled to come in, so they know who's going to need what in terms of just general healthcare maintenance, so immunizations, cancer screenings. For homeless patients, you know, making sure that there's a QFT or a PPD that's been done, flu vaccination has been given. in eye-to-eye tracks, which is a disease registry that we use. Some health centers print a patient visit summary sheet for all the patients who are scheduled the next day, and they highlight where care is missing on that patient visit summary sheet. In our EHR, there's a healthcare maintenance screen, so you can pull up that screen for the patients that are coming in and kind of scan what's going on. So I just went back to the slide that shows sort of the basic agenda that people are working to make sure they can cover in that 15-minute period and what it looks like.
Great. And a follow-up question from our audience asks, does the MA prepare the morning huddle at the end of the previous day or the actual day of service?
From what I've seen, most typically it's at the end of the previous day. And some health centers are trying to institute midday huddle as well to talk about how things went for the morning session and plan for the afternoon session. So you're not planning for all your patients early in the morning. Again, if it's a busy clinic, as we have all experienced, it can be really hard to find the time to do this. And it's not sustainable unless we also have things going on that are reducing the number of face-to-face visits. So that would be things like having group visits, doing phone-based visits, not calling patients in to tell them that their lab results are normal, being able to do refills over the phone, and having standing orders in place so that those things can be done by the team members and not solely the provider. Of course, it goes without saying, but I'm going to say it anyway, that our payment structures obviously need to change so this kind of work can be compensated. But for now, we're all looking for creative ways to reduce the number of actual face-to-face visits so that the team can go through the stages that teams go through and get to performing more quickly so that they can be efficient and maintain high outcomes for patients.
Great. And we have one more question. So participants, if you have any more, please feel free to submit those in the chat pod. And this question is on the same topic of the dyads, team huddles for Amy. How long has the team-based care model dyad been in place at your program, and how are you all planning to evaluate the effectiveness of the team huddles?
Great question. I mentioned to Julie a couple of days ago when we were doing the dry run that it might be worth exploring interest in a session on team-based care and sort of the aspects of team-based care, like the huddle, giving feedback, and some of the components. It's fairly new for our system. I mean, it's sort of implied in a lot of the patient-centered medical home concepts, and more explicitly, I would say, described in, if anyone's familiar with the Qualis Commonwealth Patient-Centered Medical Home project, you can Google sort of Qualis or Commonwealth Patient-Centered Medical Home. They did a project across the country at different health centers and health systems implementing team-based care. So, it starts with a lot of the things that Pat has discussed around role clarification, role definition, and I would be more than happy to do a session on it. It's a session within itself to talk about sort of where you start and how you start and what to expect. So to get at the question in terms of how long this has been going on, I would say it's only been within the last 12 to 14 months that there's been actual planning at our different health centers to put team-based care in place. Not to get too philosophical, but in terms of the support and the coaching we get to clinics, a year or so ago we had started to come out to try to get panel management in place, and then you find that you can't really do panel management unless people have protected time. So then for them to have protected time to do panel management, you need some role clarification. And then once you start clarifying your medical assistants' roles, then you start asking questions, well, what do our nurses do, and what about our social workers and other roles within the clinic? So the last philosophical statement I'm going to make about it is we try to put the whole team-based care model and journey, for lack of a better word, into sort of a stages of change template. So I'm sure everyone's familiar with the stages of change. So the director of the health center, in our case, we don't have center directors. It's the medical director who's seeing patients and running the health center. But you're sort of in that pre-contemplation mode. So you're reading about teams, talking about teams, hearing about teams, and then you start with your management team to plan for teams. So simple things like if we were to start just by pairing up our medical assistants and providers, and we're not in a one-to-one system, so it's really 2-to-1. Two providers share one MA in most of our health centers. How would the pairing work in terms of language, in terms of style? And then you use the PDSA concept, start a couple dyads. Don't go full force team. Yeah, I feel like I could keep talking about it. So in general, we've been working on it for the last year, and we called 2012 the year of the team. And as we near the end of 2012, we're definitely not doing teams in a standardized way, but I would say that some form of teams is happening across our 14 health centers. And, I think by 2014, we hope to be there so that we can be viable. We know that that's the way that things are going nationally, and so we just need to figure it out as well. I hope that wasn't too convoluted.
No, that was great. Thank you. Okay, so we received another question actually from our audience to both of the presenters. Asked, have either of you included behavioral health staff as part of the homeless patient-centered medical home team? Examples would be mental health and outreach staff. And if so, how does that work and who leads the huddle?
I can answer that because we do have an integrated behavioral health program in name, but like most things, the name connotes that we planned for something. Not to belittle our system, but we do have behaviorists placed in all of our health centers, so 1 to 2 behaviorists, and one of the slides that shows the behaviorist at Maxine Hall Health Center is really involved, and at that health center, so that top picture is the provider and the behaviorist. They're talking about which patients will likely need a warm handoff to the behaviorist. So that's sort of how the integration has happened so far. Again, I think we come back to the sort of trust and confidence issue and the provider becoming comfortable that there's someone else on their team that can manage some of these issues. So the last thing that I'll say about this is we did look at this concept of pathways. So we looked at the top 10 diagnoses at each of our health centers, and oftentimes it's, diabetes, hypertension, anxiety, depression, and chronic pain. 4 or 5 things that behaviorists, social workers, or MFTs are very well trained to deal with sort of from a behavioral health perspective. So it's been sort of working on what that pathway would look like, how a warm handoff would happen, and sort of what kind of trust, confidence building needs to happen with the behaviorist on the team. Probably another session within itself. Pat, you could probably speak to this.
At Charles Drew, we do pretty much a similar thing where we have the Health Disparities Collaborative. Behavioral health therapist plays a big part in it as far as the warm handoff from the provider to the behavioral health therapist. The provider, what we do is we automatically screen the patient using a PHQ, which is the Patient Health Questionnaire. If they score above, the severity score is 10 over the max is above 10, the medical provider will review and talk to the patient a little bit. And if he or she finds that there is a need for the behavioral health therapist to come in and communicate with the patient, we do what we call brief therapy, which is about 15 or 20 minutes just getting to know the patient in the beginning and trying to identify if there is that severity, or if the patient has an issue with just some kind of emotional or economical or something socioeconomic. But yes, the behavioral health therapist plays a big part in the whole process of the patient-centered home. So when the team huddles meet here, they're always included.
Great. And actually, that was the last question. We are out of time for today's webinar. So I would definitely like to thank both of our presenters actually point the audience to some more resources that we have available on this last slide. Also, if you do have any questions on this topic, we have other resources that we can send. Again, thank you to our presenters and thank you, participants. This meeting will now be closed.